I'm delighted to introduce to you a wonderful panel of speakers that are going to discuss the intestinal tract and the microbiome in systemic sclerosis. I am Elizabeth Volkman. I'm a rheumatologist at UCLA, and I'll be helping to moderate this session. And we also have another moderator today, if you want to introduce yourself.
Yes, welcome everyone. I'm Catarina Leite. I'm from Portugal, and I represent FESCA and the Portuguese Association of Patients. I will introduce you Ilaria Galetti. He is no need to big introduction because I think everyone knows Ilaria, but I can say that she's been working with systemic sclerosis for more than 25 years. She's engaged in different levels, and her main aim is to let patients have equal access to therapies. She is co-author of several articles published also in Nature, Lancet, and many others. And she is also working on new clinical practice guidelines. Then I introduce you Dr. Dinesh Khana. Dr. Khana is a professor of medicine at the University of Michigan and directs a multidisciplinary group of caregivers, scientists, and clinical researchers dedicated to advancing knowledge about scleroderma. He is leading multiple clinical trials in evaluating new treatments for scleroderma.
And then our next speaker is Dr. Chiara Bellocchi. She is an MD, PhD at the Policlinico Hospital in Milan. In addition to caring for patients with systemic sclerosis, she also conducts clinical and translational research. And she's done studies on the gut microbiome, and she's also done a lot of work on preclinical scleroderma. She's a big advocate for her patients and participates in the Italian group for the fight against scleroderma. So now we'll begin with the first talk. Ilaria.
Yes, Ilaria.
Thank you very much. Thank you for being here. Dobrý den to the Czechish patients. So today we are talking about the gut, and the Oxford Dictionary defines gut as the long tube where the food passes during the digestive process. I would like you to raise your hand if you have any problem in your tube that starts with the mouth and ends with the anus. Okay, so I think this is an important topic for us to be, let me say, more investigated. And we know it is a challenge because many things are still not known, but it has a huge impact, as you have seen, in our lives. So we start with the mouth, and the problems are common, but also very, very different. About 80% of our community experience a microstomia, so loss of elasticity, the mouth becomes smaller, and it's difficult to talk, to drink, to eat. Can you imagine the food doesn't enter our mouth really often? And it's not comfortable to go out to the restaurant and eat in such a difficult way and see other people that look at you saying, what is she doing? Didn't she or he learn how to eat with other people? But then also the oral hygiene is a challenge. And if you don't brush your teeth very well, then you have to go to the dentist. And it becomes also painful because you have to keep your mouth open for a long time. And it seems that it's broken in, it's painful, and not all dentists are trained to work with a scleroderma mouth. It's not their fault. I mean, we are rare, and also we can't expect they are all prepared to work with our mouth. But also the taste is often altered, and the pleasure of food, I mean, it's one of the best pleasures in life, is altered. And there is the burning mouth syndrome, or síndrome secca, so the dryness of the mouth. So this is just the beginning, and there are so many problems just to start the journey through the long tube. And then one of the first symptoms is reflux. So I guess all of you have experienced it, right? Who didn't experience reflux? No one, even healthy people. But for us, it's really, really common. So we have to eat small portions, often, but in the evening, lower. We have to remain sit before going to sleep. And in many cases, we have to use pillows, not to lay on the bed, which is at the end of the day, one of the most needed things, laying on the bed and rest. Sorry. Then we suffer also of dysphagia. It's not easy to, can you help me? To swallow food. And in some cases, we can't eat normal food because could be also dangerous. And we can also feel pain. Reflux is really common. We are lucky because recently some studies approached the right use of PPIs, the drugs that work on the pump protein inhibitors, to avoid exit during the reflux, because I experienced problem also to my vocal cords because of reflux. I didn't have voice. If my husband was happy, I was not, because I really need to talk. And when you have to investigate your tube, there are many tests, manometria, barium, and so on, but they are not pleasant tests. Needed, useful, but really beyond the difficulties, also needing and doing these tests adds another burden and unpleasant thing. And then let's come to the stomach. Stomach, early satiety and nausea. Every morning I wake up with nausea, even if I didn't eat much the evening before, but that's it. And the nausea also makes me have an unpleasant expression of my face, the face of nausea, disgusting and everything, but also vomiting. And if you suffer of another common symptom of a problem of systemic sclerosis, which is ILD, fibrosis, you cough. You cough a lot, and if you can't manage the cough, you need to vomit because the diaphragm goes up, and the food comes out. So, once again, we have to change our habits. We have to change habits because we need to stay set on the chair instead of laying on the bed. We have to change habits because we can't eat the food we would like to eat. And if the esophagus and the mouth are on top, then we have the second more common involvement, the small bowel. So the first of our two intestines. And in most of us, in the vast majority, is asymptomatic. But then we suffer of the so-called, I need to read because I'm not a doctor, chronic pseudo-constipation that leads to bacterial overgrowth in almost half of the patients. This, you see, constipation, I mean, I don't see the toilet for days. A friend of mine, even for 3 weeks, I think you know her, and it's really hard. Others see the toilet more than 3 days, more than 3 times a day. It happened to me. I want to talk about poo because it must not be a taboo. It's part of our life, of our disease. And due to a therapy, I had to go to the loo 13 times during the day. So once again, we have to change our habits. And of course, if I am at home and working, I just turn the screen off and say, I come back in a few minutes. Some of you saw it in the message in the chat. But then if I have to plan to travel, even half an hour, I know all the bars on the road. But sometimes it's not enough. I have to take the pills to prevent this again. And we have the second intestine, the colon, which affects from the 20 to the 50% of us. And there is less activity, can be a less activity of the muscles. And I read that nerves could be involved in this. I'm looking at Chiara because I know she did some studies about this. And also to colonic hypomobility. Again, constipation, bacterial overgrowth, and I think that most of you suffer of this malabsorption. Yeah, I don't. I mean, I have everything here, so absolutely malabsorption is not one of my problems, unfortunately. Yeah. But at the end of the story, really is a complex part of systemic sclerosis. We can't ask to make research on the gut from the mouth until the end of the tube, until the anus. I think it's not realistic. It's one part, but one part is connected to the other. And I heard some of you saying that it can be not demonstrated, but can be a relation between reflux and fibrosis. So you see how our body is well connected. And it's perfect. Yes, it is perfect. But perfection doesn't mean that everything is working ideally. I think that today, or I try today to be your voice, because I see at the beginning that all of us have problems with nutrition, with the mouth, with esophagus, or whatsoever. So really, I do understand each of you, and I'm sure that our 3 experts, know this. And why are they here? Because they have the sensibility that all their colleagues should have. And they are listening to patients, and they work for and with patients. So the floor is theirs now.
Thank you, Ilaria. Now we will listen Dr. Khana, and at the end you can make questions to everyone, okay? Thank you.
Thank you, Ilaria. That was really thoughtful and very accurate description from mouth to anus, how the gut can really affect and have a big impact on the quality of life. I think when we ask people with scleroderma, there's a lot of work that the FDA has done, focus groups asking people. Gut involvement continues to be in the top 3 areas of bothersomeness, the symptoms that really bother people, despite all the focus of clinical trials is on skin and lung, but gut continues to be an issue. So I think this slide, I'm going to try to talk today a little bit, I have about 10 to 12 minutes, talk a little bit about the questionnaire, how to capture and how to communicate to your physician. All of us rheumatologists have 15 to 20 minutes to see a patient in the clinic. And a person with scleroderma can have skin involvement, lung involvement, pulmonary hypertension, gut involvement. How do you get the attention of that clinician, me or Liz Volkman or Chiara, when we are seeing patients in a busy clinic? How do you relay this information? So we'll talk a little bit about that. So again, Chiara shared this. I just wanted to show you a slide. When we think about the gut in scleroderma, most of the people think about gut as a food pipe, but we are starting from the mouth and going all the way into the rectum and anus, including the liver. That's how we, as rheumatologists or gastroenterologists or clinicians, think about the gut. So I'm just going to talk about something that I did at UCLA. Like Liz, I trained at UCLA and I was there, and we developed a questionnaire called a UCLA GI questionnaire, really trying to capture what is happening with the patients. Can we capture the different symptoms and the impact of those symptoms, like Ilaria talked about, on your social and your physical and your mental well-being. So I'm just going to show you, I thought it may be easier to walk through, how to search for this questionnaire. You can go to Google and put UCLA SCTC GIT questionnaire, and this is where the questionnaire takes you, and it has been translated already in 34 languages that is available. So I'm sure in Czech Republic and others, there's a translated questionnaire that is available, and here are all the different languages that this questionnaire has been already translated. And then you can go in there if you want to do it today. I think it also works with your Apple phone or iPhone and things like that, and you can start clicking. There are 34 items in this questionnaire that you can click, and Ilaria and Chiara can help me translate this. This is in Italian, so I just showed a snapshot because I knew I would be with both of you, so I took a snapshot to make sure whether the site works or not. So you can go in there and click the questionnaire, and what I see, so all my patients complete it at home or before I see them. So when I go into the room, this is what I see. So as I'm talking to the patient, looking at the skin, looking at the lung fibrosis, looking at their echocardiogram, looking at the lung function, then I look at this, and I'm looking at this person, like Ilaria was saying, that this patient has some reflux, heartburn, but a lot of distension, bloating, and diarrhea. So this patient is suffering from a lot of distension, bloating, and diarrhea, with some constipation and having impact on their social functioning and emotional well-being. So when I look at this, I start thinking about the differential diagnosis. For a physician, differential diagnosis means what is causing it. The gut is very difficult because unlike lungs, where you see a scarring in the lungs and you know it's lung fibrosis, the distension bloating can come from a lot of things. It can come from what Ilaria talked about, poor gastric emptying. The food is sitting in your stomach. It can come from the bacterial overgrowth. So there are different things as clinicians that we need to think about and say, what is going on and what should I focus my 15, 20 minutes with you? So if a patient is complaining a lot of reflux, I think one thing I want to highlight that Ilaria made a very important point. Patients come to us and say, give us treatment, cure us. The best management of gut is to take care of yourself, non-pharmacological management. You have to just change your habits, like what you said. You know, unfortunately, you can't go at 10 p.m. and eat a pizza and have a bottle of wine, or maybe a glass of wine even. And I've had many dinners with Ilaria, and Ilaria is very, very careful. So you have to change. There are modifications. You have to sleep at an angle. I'm not talking about all of those, but it's very important to understand that you have to take control over your disease. If the person like the one I showed you has a lot of distension bloating and a lot of diarrhea, then I'm thinking about bacterial overgrowth. That's what SIBO is about. And I might give a trial of antibiotics for 10 to 14 days to say if the person improves. If they have a lot of distension bloating but really no diarrhea, then I might talk about taking small meals and taking prokinetics. A constipation that she talked about, there are two kinds. Constipation that has a normal transit, the gut is functioning fine, where laxatives and others would work, but then there are constipation where the gut is moving very slow due to scleroderma. In that case, you know, laxatives are not going to help. You need some stimulants to push the stool out. So just to highlight that when you go to your physician next time, if you have done that, and a lot of my patients print it and bring it to me, they say, Dr. Khana, I know you like looking at this stuff because you only have 15 minutes with me, so can we address A, B, C? So that really helps us to focus on that. There are two topics that I see as Scleroderma Foundation CEO out here that needs updating, and maybe folks can work here. This is something I wrote, the digestive involvement in scleroderma. I think it has been updated since 2012, and with a patient who was also a dietitian eating well with scleroderma. But these are very old, and they need to be updated based on the new information and the knowledge that we have. So then I thought that I will take the remaining 7-8 minutes, since nobody's talking about how, as a physician, I manage it. So I will still stress liberal use of water, trying to make sure that you have regular dental appointments. And you have to find a dentist that can go in the back of your teeth. So most of my patients who have decreased mouth aperture go to pediatric child dentist. That's where I usually send them so they can get the dental cleaning. Because most of the instruments, if you go to an adult dentist, do not have enough small instruments that they can go in the back of the mouth and clean it. This is from a dentist that works with the NSF, National Scleroderma Foundation, Dr. Leader in Boston, who has been a big proponent and has taught me quite a bit on the management of the dental health. These are different products that are available: fluoride, calcium phosphate to strengthen your teeth, xylitol-containing products for dry mouth. A lot of you have dry mouth. You shouldn't be chewing or eating sugar candies because that will cause cavities. So there are some examples out here that had been advocated by different dentists that you can buy everything on Amazon these days, so you can get these on Amazon. Adaptive devices. It's easy for us to say you should use a toothbrush. The best one, of course, is an electric toothbrush you should use, but there are adaptive devices that I'm showing you out here that can help you go in the back of the teeth and clean and to floss and other aspects. So do remember that as you take care of your dental hygiene. Reflux. So the most important thing you can do for reflux that all of us maybe should do is to sleep at an angle. So sleeping at an angle and buying a wedge. Again, you can go to Amazon and buy the wedge, And I hope you get this joke from me that I had a patient who I asked them to get the veg, and they bought the veg, and they came after 3 months, and they said, our symptoms have not improved because they increased the whole 4 legs of the... The veg is only for the head side of the bed. This is a real story. So, you're supposed to only raise the head side of the bed when you do that. Do not use pillows. I know all of you are here. Pillows is not a good idea because if you prop yourself with the pillows, by the time you wake up, the pillows is either on the top of you or you're really bent, and that puts the pressure. Do not use tight belts because that can increase the intragastric pressure. It's easy for us to say do not eat late, do not drink fluids late, and things like that, but again, changing the lifestyle really helps out here. And if you can afford it, there are now electric beds where you can raise the head side of the bed and you can control it, and that may be very, very helpful. Not every reflux is acidic. So although I can give you a proton pump inhibitor, if it's not an acidic reflux, it's not going to help you. You may still have the non-acidic, what we call alkaline reflux, come up your food pipe, cause hoarseness of the voice, change in your voice, or even go into your lungs, and may cause lung fibrosis. So we do not have medications that we can give you to help you to treat it. So the best thing you can do is let the gravity keep the acid and the non-acidic fluid into your stomach and down. We all take, well, we not all, you all take proton pump inhibitors. You know what proton pump inhibitors are: Prilosec, omeprazole, Prevacid, lansoprazole, and there are about 5 or 10 of them that are available in the market. The key part of the proton pump inhibitor is to try to take 30 to 60 minutes before meal. There's an interaction with cell sept. So that is a bit challenging. It reduces the efficacy or the levels of the mycophenolate or cell sept in the blood. So if possible, I tell my patients to take PPI, take cell sept in the morning, the first thing, and then wait, and then start to take PPI 2 hours later, and things like that. If possible, it's easy to say than to do it. We usually try to keep it to once or twice a day, but it's important that you don't have symptoms. A lot of patients don't want to take proton pump inhibitor because they're scared of long-term side effects, some of which are real. Osteoporosis. There have been some reports of dementia. There have been some reports of weird infections that have happened with them. Most of those data come from large administrative databases where thousands of people are taken in a US database, not in people with scleroderma, but these risks are real. However, if you continue to have acid reflux, you are causing scarring of your gut. You may be worsening your lung fibrosis, and then very rarely you can get a cancer of the junction of your food pipe and stomach, and that's what we are trying to delay, decrease, or prevent. If you still continue to have symptoms, if you're taking proton pump inhibitor twice a day, and you still have a lot of reflux, acid coming in your mouth, food coming in your mouth at night, I tend to refer at that time to gastroenterologists so they can do a scope. And the scope is helpful to look at the stricture, which is a contraction, a fungal infection, and to do further testing. So here's a patient who has quite a bit of fungal infection that you see out here, the white stuff that sometimes people get in the mouth called candidiasis, that can be seen in people with long-standing scleroderma who continue to have symptoms. Stomach, you talked about, Ilaria. These therapies are not very effective, I have to be honest, and these therapies all carry a black box label. In other words, all of these can cause a little bit of arrhythmia in your heart, may cause. So you must get an EKG or an ECG of your heart, and your doctor should do it before they offer you any of these drugs that increase the motility of the gut. So what we are trying to do is think about scleroderma and gut involvement having fibrosis and decrease electric network that has been damaged because of scleroderma. So the things are moving just slowly. They are moving just slowly. You ate a big meal yesterday at night and the food went into your stomach. Now usually the food gets out of the stomach in 1 to 2 hours, but in your case it may be sitting there for 4 to 6 hours. you start to get distended, you start to get bloated, you sleep at night, the food comes up. So with these drugs, we are trying to push and increase the motility of the gut. That's what we are trying to do out here. And here are 4 therapies that I have given out here. But in my practice, I have not found them to be really, really effective out here. There's something called fibromyalgia of the gut that we have a big interest, and we know we are doing a lot of work at Michigan, that people just have symptoms that everything seems to be okay, but the symptoms are a lot of distension, bloating, a lot of abdominal pain and cramps and things like that. And our gastroenterologists give this medication called Buspar that seems to be somewhat helpful. And again, we work with our gastroenterologists closely trying to treat this. Bacterial overgrowth, you can do testing for it, or if there are symptoms of, like the first patient, a lot of diarrhea and distension, bloating, I tend to give a course of broad spectrum antibiotics. You may give it for 2 weeks. I don't know if somebody has bacterial overgrowth here. The bacterial overgrowth, sometimes people take cyclical antibiotics, 2 weeks on, 2 weeks off, 2 weeks on, and with the pro-motility agents to push the things. Now the laxatives are good. Now we are going from the small bowel into the large bowel, and you're really constipated. Laxatives are good. Laxatives are good if you have a normal transient gut functioning. We are very interested. We do a lot of testing that we have been doing with the certain markers to see whether the gut is moving fine, where the stimulants, good hygiene would be helpful. But if you really do have very slow transient, a lot of constipation like Ilaria was talking about, because the gut is just moving very, very slow. Here are 3 medications that have been FDA approved. I'm sure they are available out here for idiopathic constipation, and a lot of rheumatologists and gastroenterologists tend to use these therapies. Here, taking a lot of food with a lot of roughage is not going to help you, because it can promote worsening of your constipation if you have a slow transient. So it's important for me to know whether the gut is moving fine, the lower gut, or it is not. And I think this is one of my last slides. Fecal incontinence. Nobody talks about it. The patients are a bit hesitant, but it's very important. It has, I think, one of the biggest impacts on quality of life in people with scleroderma and gut involvement. In the surveys we have done, the UCLA GIT questionnaire has been completed by 22,000 people so far. Because every time you complete it, anonymously I get a score. I mean, I can go in there and in which country people are doing. About 30% have some fecal incontinence. 30%, 30 have this. And if you go to your rheumatologist or gastroenterologist, they show you the pelvic floor exercises. But if it's really bad, sacral nerve stimulation. So it's like a credit card in the back that stimulates the sacral nerve that can help control the anal sphincter and can really help reduce the episodes of fecal incontinence. And we have done it in about 20, 25 patients and has been quite successful. So I think one of the things that we have been talking here and thinking about here in US is how can we teach people who are primary care doctors, who are nurse practitioners and others about scleroderma. So we are just launching a CME with the Friends of World Scleroderma Foundation, which is the Friends of WSF, which is really targeted to teaching the associate, the allied health professionals and the primary care doctors and the others, what is scleroderma. So trying to reach, not to the rheumatologist anymore, trying to really reach to the people where you have the first contact with Raynaud's and other aspects. So again, GI involvement is very common, probably the most common symptom that has a big impact on quality of life. Be proactive. Talk to your patients. Talk to your doctors. Your doctors are more focused on skin fibrosis, because skin fibrosis, as you heard here, is associated with internal organ involvement. We are more worried about lungs and pulmonary hypertension because they are the leading cause of death. But your symptoms matter. If pain, fatigue, GI symptoms are bothering you, it's important for you to bring it to them and push them to really do the appropriate testing so they can manage you appropriately. I think that's about it. Thank you.
So, hello everyone. I'm really glad to be here today. So, I have to talk about gut microbiota. It's a very extensive subject, very difficult. So, I try to do my best for you. I want to give you a sort of guide in way you can understand when you read the newspaper or even scientific reports about that. So, let's start with definitions. So, what is microbiota? It's a set of bacteria, fungi, and viruses, so not only bacteria, that are in a specific location of the body. So we can have a gut microbiota, but also microbiota in the skin, in the oral cavity, a nasal microbiota. While with microbiome, as researchers, we refer to the genome of all the microbes present in a given ecosystem. So it's a little bit different. So in the gut, we have, in the colon, we have more than 500 different species of bacteria. And we can have two different kinds of that. Commensal bacteria, so this term means that are not harmful, so they are good. And we can have also a situation in which we have pathobionts. It means that they can cause harm, they can be bad under certain circumstances. Another term that you can hear very well is dysbiosis, and it is an imbalance of the normal microbial community that has relevant consequences both from the immunological and metabolic side. So a normal human gut microbiota, we can say that is on average dominated by two phyla, Bacteroidetes and Firmicutes, with other minor that are here listed. So you see that I'm talking now about phyla, phylum, and before I was talking about species. So it can happen that you read these different terms. We are talking about the same thing. As you can see from the example on the right, this is the fox. You can refer to the animal talking about its kingdom, phylum, but also more deeply about the species, okay? So it's the same thing, different name. So let's go now to the second part of this presentation. So why is so important gut microbiota for the immune system, why we are studying it? It's important because we have evidences, for example, that when we are delivered, so at birth, so children that are delivered from a C-section or on the opposite with a vaginal delivery have a different gut microbiota. They inherited this from the mother. So usually, so we don't, at birth we don't have it, so we develop it. And also if we have a child that is fed with breast milk versus formula, these children have different gut microbiota. And this gut microbiota is so important because it's able to shape and to let the development of the immune system. It can shape both innate and adaptive immunity, but even more important, this is fundamental because it's able to stimulate anti-inflammatory cytokines and the regulatory immune functions, so T regulatory lymphocytes. And they are able to do it through the metabolizing oligosaccharides into short-chain fatty acid. I just cite short-chain fatty acid because this is another term you can find reading about gut microbiota. We have evidence also in food allergy, for example, that an early dysbiosis, so if you give too many antibiotics to murine models at the very early stage of life, they can develop allergies. So we are sure that there is a communication between gut microbiota and the immune system. So let's now go talk about autoimmune diseases. So let's go deeply. So we talk about, in general, immunity, and now we go deeply looking at autoimmune disease. So this slide is just to show you that gut microbiota was studied in many autoimmune diseases, systemic one or not. So we have now evidences in Sjogren's syndrome, type 1 diabetes, multiple sclerosis, lupus. The first disease in which was studied was IBD, so inflammatory bowel disease. And we know that in these patients, if compared to healthy controls, we have dysbiosis, so we have a reduction of commensal, remember the good bacterial, and an increase of pro-inflammatory bacterial. In lupus, we have evidences both in mouse model, but also in patients, and we know that also in lupus patients, there are differences between healthy subjects versus lupus patients. But let's go deeply now on systemic sclerosis. So what is the state of the art? This slide is to show you the very first studies that were conducted on this subject in systemic sclerosis patients. So the first study was done in 2016 by Elisabeth Volkmann, that is here today with us. And all the studies that you see here listed investigated the difference between systemic sclerosis patients' gut microbiota and healthy controls. And we found that patients have a unique microbial community that is different from healthy controls. This is just to show you very quickly what we have done in Milan. So we compared 59 Italian Scleroderma patients versus 29 geographically matched. This is another important thing about geography, because we eat the same things almost. And we found out, for example, that in our patients, there was a decrease of good commensal bacteria. Lactospiraceae family, they are very good because they can induce immunoregulatory function. So researchers wanted to have other questions. So let's say, what can happen if we compare two groups of systemic sclerosis patients, but from two geographically different places? So Elisabeth Volkmann and Dr. Von Volt from Norway, they did it, and they found out, for example, that the extent of dysbiosis was greater in the UCLA, so in Los Angeles cohort. Also, other question arises. For example, is the gut microbiota correlated with the presence of interstitial lung disease, with telangiectasia, pitting scars? So yes. One of the authors of these papers, so Dr. Andersson from Sweden, he found out, for example, that gut microbiota show a dysbiosis in systemic sclerosis patients even in the early phase of the disease, so in the first 2 or 3 years. And he worked a lot with the Sweden Patient Association for doing this research, very good research. And another question is this dysbiosis correlated with symptoms? So yes, we can say that yes. And from the study, the evidence shows that great dysbiosis is correlated with the GI symptoms. This is just to show you the very last study that I found on PubMed. And this is from the group of Silvio Berlando Randone in Florence, and they investigated 25 Scleroderma patients, looking not only at the gut microbiota, but also at the skin microbiota and the oral microbiota. So again, to tell you that we can investigate microbiota almost everywhere. So let's talk in 10 minutes about interventional strategies, because I was asked to talk about that. So I want to start from the easier thing. So probiotics, I'm sure that you heard about them. So probiotics, the definition is that they are live microorganisms that can confer health benefit. So the most known probiotics are, for example, Bifidobacterium or Lactobacillus. Okay, but we have to say that if these probiotics are given frequently, for example, in Italy, they are given after taking antibiotics for an infection. We cannot say that we have evidences that these probiotics are really working. Especially, we don't have yet evidences in systemic sclerosis. So pay attention. Also because these probiotics, for sure, are safe, well tolerated, but mostly of them cannot survive to the gastric acidity. So you have to pay attention to not to waste money and use strains that are able to pass the gastric acidity, otherwise you are taking water. Prebiotics, so we can define them the food of the probiotics, okay? Just to be very simple. These are these substrate that bacteria use, and they have an advantage, so they can pass the gastric acidity. So they are good to go down and into the colon and to be metabolized. So we have different results. So in IBD patients, there are conflicting results, while in HIV patients, there are very good results in improving symptoms that even in this disease we have. So about dietary modification, this is a very huge topic. So I'm sure that Elizabeth Volkmann will talk a little bit about that. So I'm just saying here that obviously we can change the gut microbiota. We can shape it also with food. So this is very important. Food can be considered a medicine. But we need studies. We need studies that are strong to say we cannot now prescribe a diet, the correct diet. We can just give suggestions, but a diet as a medication is not impossible to give. And now I was asked to talk about fecal microbial transplantation. I don't know if you ever heard about that. So I'm going a little bit slow. So basically,
We have to finish, okay?
Okay. So basically, you take fecal samples from healthy donor, you process it, and then nowadays we can have 4 different preparations. We can have fresh fecal preparation, a frozen one, fecal capsules, and a wash microbiota preparation with an automatic purification system. This is very new, okay? We can give this fecal microbial transplantation through many delivery methods. Nasal tubes, the capsule can be given orally, through colonoscopy, and this technique was investigated in different diseases. One of the first studies was in patient that had infection with Clostridium difficile. What we know in Scleroderma, we know that one study was performed in 2020 from the Norway group, and so they saw that this treatment was safe and well tolerated. In this very pilot study, they saw that was maybe associated also with an improvement of symptoms. But I have to tell you that as I saw yesterday a presentation of the rescue trial, another trial that showed us basically that the symptoms of patients did not improve really with the fecal microbial transplantation in systemic sclerosis. So we need further studies, okay? And we can conclude so that additional research is needed to determine, establish the safety of this procedure, but also, again, to look if we are improving symptoms. Otherwise, no sense to use something that is not giving us good results. I want to thank all my colleagues from my clinic and our lab. I really want to thank you, FESCA, and the World Scleroderma Foundation to be here today. I really believe that the relationship between the patients and researcher is very important for research. And I'm here today as a researcher because I was funded by the Italian Patient Association, GILS. So I really thank you all to be here.
Okay, we're running a little bit behind, so this is going to be a briefer presentation. But again, I'm Elizabeth Volkmann. Can we bring back up the... There we go. And I'm a rheumatologist from UCLA, and I've done a lot of research on the gut microbiome, as Dr. Bellocchi said, and I'm very interested in nutrition. Can you... There we go. Okay. Normally when I talk about nutrition, it's about an hour and a half talk, so this is extremely condensed. And I just wanted to focus on a few principles that I find that help my patients. But I think for many of you, when you were diagnosed with scleroderma, you probably got a lot of advice from your family and friends about what you should be eating. And maybe you went to a support group and someone told you what has helped them. But I will tell you from the beginning that there is no one diet that works for every patient with systemic sclerosis. As you know, you are all unique individuals. You are from different cultures, different genetic backgrounds, you live in different areas, and all of this affects how you process food. So just keep in mind that what works for somebody might not work for you. And I think that the foundation to improving your nutrition with this disease is to learn how to connect what you eat with how you feel. So I, as Dr. Bellocchi said, think of food as part of your medicine. They can extremely affect how you feel. Sometimes you'll eat a food and you will feel energized and nourished. Other times you might eat a food and feel depleted, or you might have worsening distension or bloating. If you learn how to connect your feelings with the food that you're eating, this will help you a lot on your journey. I also think it's very important for all patients to practice mindful eating. So in our busy lives, we often eat while doing other activities. So while I live in Los Angeles, so I spend a lot of time in my car in traffic, and I see many people eating while they're driving. We often eat while watching TV. And the problem with this is that when you're doing other activities, your body is not in a restful state. We call this the parasympathetic state. And this is the state that your body needs to be in order to digest food properly. Also, if you're eating while you're distracted, it's going to be more difficult to remember what you ate and to connect those feelings with the food that you're eating. So what is this parasympathetic state? I'm sure you may have heard of the sympathetic state. This is the fight or flight response. This is the state of your nervous system that you'll go into if you're under stress. And when you're under stress, you don't digest food well. You need to be in this parasympathetic state, the rest and relax state, in order to properly digest your food. So I would highly recommend that when you're eating, just take a few moments before you eat. If you're eating at home, try to clear your area of any kind of stressors. So I wouldn't suggest sitting down to eat and looking at a stack of bills or something that could trigger you in some way. Again, I wouldn't suggest eating while watching the news or something about a war, because again, this will get your body into a more stressed state and it's going to be more difficult to digest your food. Try, if you can, to do something calming before you eat, even if it's just for 10 minutes. This could be taking a warm bath or shower, and this can be very helpful when you have systemic sclerosis because you don't want to be cold when you eat. It's going to be more difficult to digest your food. So you can warm your body up, and this can also be relaxing. You might want to listen to calming music or even do some deep abdominal breathing. But try not as best you can to eat when you feel stressed. And then the next step is to create a food diary. It's often very difficult for us to remember what we ate a few hours ago, let alone yesterday or the week before. So the only way to begin this journey of connecting how you feel with what you eat is to start a diary. And it may seem very tedious, but it's actually a good practice of self-care to spend some time on yourself. It's a really simple way, again, to connect specific foods with feelings. This is just one idea, but there's no one way to do a food diary. But I suggest thinking about the symptoms that trouble you on an everyday basis. And so for many people, they are troubled by fatigue or pain or stiffness. Brain fog is a common symptom of patients with autoimmune disease. And then any other symptoms. It could be diarrhea, it could be constipation. And then each day rate the level of severity for you. And you might get really complicated and have a number system. This to me is very simple, none, some, a lot, but place an X in the box of how you feel, and then write down everything you ate that day. And keep in mind that you may have symptoms one day that might not relate to the food that day, but the food you ate the day before, even 2 days before. When you start doing this practice, again, it may seem tedious, but it's going to help you make these connections. I also think it's really helpful to create a team to help you on this journey. So you may have a rheumatologist and gastroenterologist that you see, but you may consider trying some Eastern medicine like acupuncture, which can sometimes be very helpful. Nutritionists are also important on this journey, and there's a big connection between stress and what's going on in your life and how your gut functions, so maybe even a therapist could be helpful for you. I do recommend, though, only working with licensed healthcare providers, and you may have to interview a few providers to find the right one for you. And anytime you're going to make changes to your diet, you want to talk with this team to make sure that these changes are good for you from everyone's perspective. If you go on the internet, I would just recommend having some caution, especially if you're on social media. There was a time when I was on Instagram giving advice to patients, but I would notice that there would be a lot of people that claimed to be experts in nutrition giving advice, and really they weren't qualified to be giving that advice, and they didn't know about the specifics of scleroderma. So have caution if you come across someone that tells you they can cure your scleroderma with diet alone. This is just not possible. This is a very complicated disease, and diet is just one part of the journey when you have this illness. And a lot of the information you might find on the internet can be contradictory. So some people say, eat gluten-free, some people say, don't eat gluten-free, and this can just get very confusing. There's really no substitute for connecting what you eat with how you feel, so you're going to be your best guide in determining what's the right diet for you. And then, I think it's important to be open to change. So some of you are just starting your journey with scleroderma. Others of you, like Ilaria, are 25 years into it. And the thing is that at any point on this journey, you might have to adapt how you eat. It could be that, it's colder where you live this time of year, so you want to have warmer foods and you want to avoid cold, raw foods. You may have a new medication that you start, and that medication causes diarrhea, which you didn't have before, and now you can make some adjustments to your diet. So again, just be open to change. What works for you now, maybe 5 years from now, you might have to make some tweaks. But as long as you're tuning into how you feel after you eat specific foods, this process will come more easily. So just to summarize, again, relying on nutritional advice from individuals on social media, the internet, can be problematic. Really take caution if anyone tells you they can cure you with diet alone, and a lot of the information that you read on the internet will be contradictory. So the best way to start this journey with nutrition is to really go inward and try to make these connections between specific foods and how you feel. Again, this was a very short talk because we don't have a lot of time today, but I do have a newsletter that I send to patients monthly, and if you click on this link, you can receive this newsletter, and I give a lot more in-depth tips about nutrition when you have scleroderma, as well as other self-care practices. I don't know if we have some time for questions or we should wrap up. Yeah, so maybe just 1 or 2 questions, okay? Thank you.
So if we have there, and in the meanwhile, we must stay connected with the 3 of you, because I saw everyone paying attention. No one was checking WhatsApp or whatsoever. The only use was to take pictures. So yeah, thank you.
Have you got experience or treatments to achalasie? it's, oh God. Did you know anybody Achalasi?
The question is if we have treatments.
Yes, yeah.
So, good question. Now, it depends obviously on how bad it is. For sure, what we give to the patients are therapies that can give reliefs to the symptoms, because it's very common in patients. So sometimes we don't see it at the beginning of the disease, but it starts to be there. So we give anti-reflux medications, and then we send the patient to the gastroenterologist and see if something more invasive is needed to do. About the dietary modification, again, I can ask Elizabeth, but...
Yeah, I think that, if you suffer from achalasia, and this is, when there can be narrowing in the esophagus, and some people even get things like strictures, it can be very helpful to eat food that's soft. So soups are very good, pureed vegetables. You don't want to eat any hard, rough food, so it's often very difficult for people to eat large pieces of meat. And also dry foods can be difficult. So even if it's a cracker that you think, oh, this will dissolve in my mouth, it will go down easy, when you have what Ilaria said in terms of the dry mouth or the sicca symptoms, if you have dry foods like crackers, bread, chips, this can actually make the dryness worse, especially if they have salt, and that's going to be more difficult to swallow as well. So if you have any difficulty with swallowing, as many patients do, you want to think of having moist foods that are easier to swallow. Great question. I think we have time for one more.
I have one. There is a question in nutrition that always come out in the patient meetings in my country, that is about gluten. Also, people also ask, there is evidence that taking off gluten off the food is good for scleroderma. Is there any truth in that, or?
No, it's a great question, and I don't think for all patients it's necessary to eliminate gluten. And I would also have caution because there's a lot of marketing around, gluten-free foods now, and many of the gluten-free foods are food that come in packages that are very processed. And processed foods are foods that have more than about 5 ingredients. So if you look at a box or a bag of food that you're eating and you see more than 5 ingredients, and maybe some of the ingredients are names that you can't even pronounce, like chemicals, this is a food that's been processed. So things have been added to it, and processed foods really do disrupt your gut microbiome. So the caution I would have is if you decide to try a gluten-free diet, try not to fall into the trap of eating these gluten-free crackers and breads, because sometimes they're more unhealthy for you than having some gluten. But many patients feel better, and this is one of these things where you could try doing gluten-free for about 2 weeks, see how you feel, do your food diary, and then the next week add back in the gluten and notice if there's any change in how you feel. And if you feel worse with gluten, then try to lower it. This is a long topic, so we thank you for your time today.
Thank you.